Dr. Dan Edney's in, past president of Mississippi State Medical Association, and he's also chaired now the Mississippi Healthcare Coverage Access Review Executive which is called MH Care Task Force. Good morning, sir. How are you?
Good morning. Thank you.
It is good, as we talked about earlier, to be on and talk about something other than COVID.
That's right.
But just at 834 cases yesterday, down a little bit. And we had 19 deaths yesterday, which is also down. So hopefully we're seeing some good news on that. All right, let's talk about it. First of all, this is a new organization, new nonprofit.
No, it's a task force that
been there for a while,
organized by the State Medical Association, knowing the importance of expanding access to health care for low-income working Mississippians, and knowing that our membership base had a diverse opinion about Medicaid expansion over the last decade, we chose to just reevaluate everything. And so a 25-physician task force made up of different specialties, different geographic areas in the state, different ages, different political thought, and different opinions on Medicaid expansion was convened, and I had the honor of chairing that. And we spent a few months talking to all the stakeholders in the state, the political leaders, Medicaid leaders in other states that have had experience that we were interested in, to come up with what we feel is the right path forward for Mississippi. Before you do this and put your stamp on it, do you have to have like 51% of the members, or you just make that decision? Well, as of right, and it was unanimous. It was unanimous among the task force members, and it was not in the beginning, but it was at the end. And among our membership now, in terms of expanding access, that's what we're talking about. We're not talking about Medicaid expansion, Obamacare. We're talking about expanding access to the working poor of Mississippi. All right, how do you do that without expanding Medicaid? Medicare. By taking Medicaid, by taking the $1 billion that's on the table for us from the federal government, and either through an 1115 waiver program or through amending the state plan amendment to do it the Mississippi way, whatever will work for us. It does not have to be Obamacare. It's just dollars coming from the federal government. Well, even to mention the word Obamacare is toxic to most people. Which is why we don't do it. And so is Medicaid expansion. Yes, Medicaid expansion. So, but by not using his name or that name, but doing basically the same thing to expand Medicaid, the cost is going to be the same to the federal government. The deal we get is going to be about the same. Would the services be about the same as if we expanded Medicaid to those in, let's say, the higher income group of 138%? It depends on what we do with it. And looking at other states and understanding that Medicaid expansion was not on the table, so we didn't really look at that. There was no need to. But we did look at Indiana and Arkansas as very good, well-proven models, especially Arkansas, because Arkansas is very much like Mississippi politically. They're higher population, but their socioeconomics are similar, demographics are similar. Yep. Their political leadership is very similar. And they chose to go the 1115 waiver route, and they took their $3 billion a year and invested it in privately held insurance plans, policies for the working poor of Arkansas. And that had great benefits throughout the whole economy of Arkansas. Basically, we have been doing that in Mississippi through the CHIPS program for low-income children who don't qualify for Medicaid. We buy them a Blue Cross policy. Right. We're talking about doing the same thing for their moms and dads who are out there working 2 and 3 jobs, who are paying taxes, who are paying their bills, who are paying their sales taxes, who are working hard, doing the right thing, but they are on the edge, making $34,000 for a family of 4, or $17,000 a year for a single individual. You just cannot buy private insurance with that income. You can't do it. Is that the cutoff at $34,000 right now? That would be 138% of the federal poverty level. Okay. $34,000 for a family of 4. Family of 4 is 30 what? $34,000 for a family of 4. So right now, anybody under 34, 33 and below is already qualified for Medicaid? No. Medicaid in Mississippi is pretty strict. You basically have to have children in the home, be pregnant, have someone disabled in the home, or truly impoverished. If you're working poor, you will not qualify for Medicaid in Mississippi unless you're pregnant.
What is it that your organization let me go through the bullet points of exactly the numbers, if you've put the numbers out so far, and what your plan looks like on a waiver. Do you have the numbers on those?
Yeah, well, we would recommend.
I know you mentioned the 34,000, but
we're talking about providing excellent health care coverage for another 140 to 160,000 Mississippians that would not be Medicaid. It would be whatever private product that the state chose
What's
to buy.
the cost per family or individual? Do we have that cost?
But we don't know what the market would be.
That the taxpayers would have to pay.
Well, but the taxpayers would only have to pay. The governor keeps putting up $300 million a year. That's to draw down $1 billion. We think that number is less, but we think there's more benefit in the system than $300 million a year to Mississippi, which is what the state economist has said. And, we think there's more than $300 million amount of waste in the current Medicaid program that we can get the money out of what's already there.
No doubt about that. We understand that.
We think we can do this without any additional taxpayer dollars from Mississippians.
How many more people? You said 140,000?
140 to 160,000.
Is that capped or is it open-ended?
It's capped at 138% of the federal poverty level. So that would, for Mississippi, that's about.
But anybody moving into Mississippi who is in that group, they would be able to partake of that.
Yes, if they're a resident of Mississippi and they qualify for
when you
income.
say capped at 140,000, it's not capped at 140,000. The number of people who could.
The number's not capped. It's just the income is capped.
Nothing about a savings account on this, a health savings account, or how do you work that?
Yeah, we looked at that. Again, Arkansas is the great model for us, and there's some benefit us being 10 years behind because we have
seen mistakes they made.
We've seen what's worked and what has not worked. We know that work mandates are unconstitutional. That's been dealt with. Arkansas tried that. It was unconstitutional. And they tried health savings accounts, and they just weren't taken advantage of, and they were cost prohibitive for the program with low benefits, so they scrapped it. But there was not much demand for it with that income group.
One of the things that I've read in the past is that when people initiate this and put a expansion on and a whole new group of people move into it by the hundreds of thousands, many of them had insurance and understand they were fighting to keep that insurance. But when they canceled that private insurance, it did have a deleterious effect on the market.
So this is what happened in Arkansas.
Yeah.
The state of Arkansas had $3 billion to invest in the market because that's where the money is going. It's not going into the Medicaid program. It's going into the market. And what happened was there was new competition. Instead of it just being Blue Cross of Arkansas, much like it is in Mississippi, Blue Cross Mississippi has 80% of the private market. All of a sudden there was competition, and what happened was everyone's premiums went down. The market stabilized, and because of the infusion of guaranteed
they didn't go
purchase,
up, they actually went down.
They went down for everyone, including private policyholders, which is very expensive. Their premiums went down.
Well, we're in the mood to talk more about this when we come back in just a moment or two. Dr. Dan Edney, who is past president of the Mississippi Medical Association, also current chair of the Mississippi Healthcare Coverage, which is MH Care, the task force. And we were talking about the expansion. You mentioned to me off the air, we were talking about it. You said we are subsidizing Arkansas. And Perez, I don't want to correct you, sir, but you got to turn his mic on. Thank you. See, you were worried about me. Gotcha. Okay, go ahead, sir.
Yeah, as a conservative Mississippian who's paying taxes and paying a lot of federal taxes, a lot of my federal taxes are going to these other 39 states that are taking the federal money and expanding access by whatever way they choose. My preference would be to go the Arkansas route and take the $1 billion that's available from Mississippi, and Mississippi purchase $1 billion worth of insurance for the working poor of our state, and that will benefit everyone. It will improve access to health care. We know that through the CHIPS program. These kids have had wonderful access to health care through the CHIPS program since the 1990s. We know that program works. It's probably the only federal program that is cost-effective, saves money, stabilizes the market, improves access. We truly believe, based on the Arkansas model, the same thing will happen in Mississippi for their parents.
I know your task force has looked at this because it's not that just the conservatives in the state, and of course they are all Republican for the most part. They're not just being mean. There are some concerns. Have you been able to narrow down, laser in on the concerns? And I would think that the concerns are, having many of them on the air, is that can we afford this if the federal government, for some reason or the other, says, I'm sorry, guys, we're not going to send you a check anymore. You're going to have to pay for this whole thing yourself. All of a sudden, a politician is faced with cutting 200,000 people off of their health insurance, and that is a re-election nightmare. You think that I hit the head on the nail on the head?
Absolutely. And that's what we've been looking at for a decade, and those fears have been unrealized. And when is the last time the federal government ever pulled a plan back?
Yeah, but it's still, there's a lot of first-time things going on in Washington.
So if
right
they
now.
Did, which is worse, never to insure the individuals that have gone uninsured for the last decade, or to down the road have to cut the program back because of cost constraints?
No, I understand. Couldn't it be placated to the members, certainly in the more resistance in the House than the Senate, by just saying, look, if this program ends in Washington, then
we end it here.
You're going to either end it here or you're going to be given some nominal fee, cost per month.
Yes, and the same thing would happen with CHIPS. If the CHIPS program went away at the federal level, it would go away at the state level. Same thing would happen, with the expanded access for their parents. If that $1 billion goes away, we can't afford to do it on our own. But currently, we think we cannot afford not to do it. We have to do something. This is costing us too much money.
Well, some of the legitimate concern from some members of the House and Senate is this: if we do this and it becomes a financial liability, it's not being mean, we are risking the people who are on there now below the 138, the people who are now getting CHIPS or now getting Medicaid.
We don't see that as being a viable risk. The money the federal government is so determined to do this that they're virtually asking to pay for the whole amount. Mm-hmm. That's before Congress now is to take away the 10% state match, is to make it a 100% federal program. All you have to do is take the money. At this point, for us not to take advantage of this $1 billion investment in the economy of our state has to be political. It can't be economic. Economic leaders are looking at this just as we are looking at it. It makes financial sense to invest the $1 billion a year into the healthcare infrastructure of our state, improve access, improve health incomes. Finally, we're the sickest state in the union. We need it more than anyone. It is just it's a form of insanity for us not to do something to make ourselves better when the money is right there.
The Mississippi State Medical Association supports the potential use of an amendment to the current state plan. How's that played out?
The problem with the 1115 route is that's through the Division of Medicaid. CMS requires there be a waiver application from the Division of Medicaid, which is through the executive branch. Mm-hmm. Presently, that's not going to happen. We've been told that's not going to happen. So the only other alternative route is legislatively to amending the state plan. And we do have a pathway there. The lieutenant governor is very open to this. We do have House Republicans that are business Republicans that are listening to business leaders that we've got to do something. And very soon, I think there will be a strong coalition of hospitals, physicians, business leaders, and faith leaders, because this is basically, brass tacks, this is just doing the right thing. My mom and dad were working poor growing up in the Delta. I'm first-generation college graduate, much less physician. I was the child. I would have been on the CHIPS program back in the 60s. My parents had to work harder to provide health care for my family than they really needed to, working 3 and 4 jobs. It's not 1970 anymore. We can do better, and we should do better than Mississippi did in 1970.
When we were talking about this off the air, had an energetic conversation going. And my point on this is, sometimes when we get this passed, if the House Senate did it and the governor signs it, we think hunky-dory, everything is hunky-dory, everything is kumbaya. But we don't look at the plan itself. Is the plan working? Do we have things built in there? Are there yearly physicals required, or whatever it is? Are there some obligations on the people who do this, other than you're just taking advantage of it when you have to run to the doctor? Is there anything in there that helps these people? Maybe at the end of the day, when statistics are gathered, that they are healthier.
Sure, that's part of the beauty of going this route. Is it becomes the Mississippi plan, not the Arkansas plan. Mm-hmm. We take what we know works. So that hasn't been
put together yet.
Not yet, because if there's an 1115 waiver, that has to come from the executive branch. But we would be very happy to help that be brought together, and it should have proper performance evaluations in it to make sure it's doing what we want it to do. We know that CHIP's plan passes its performance evaluation.
It does.
It does, and we think. Yeah. And we would want whatever form of expanded access that we chose, that's best for Mississippi, to do likewise.
I don't think it's heartless to say this as a stockholder, and that anybody who's paying taxes that makes this available to those who are not paying for it has some legitimate reason to say this, is that we want to make sure not only that we do it, but we do it the right way that is helpful. Because if you say that, I don't think you can have the same numbers for just the general Medicaid population, that they are better off, or if you're doing a past performance, would they pass that?
Which is why we don't need to do Medicaid. That's why we need to do
our own thing.
To take that $1 billion and buy private health insurance for these hard-working Mississippians, and it will improve access, which will improve their health, and we'll have a healthier workforce for it.
And I know it sounds mean, but you stay back, you look at how long we've had Medicaid in the state. It's been quite a while. And then you go back and you look, is the health any better? But every day Perez and I sitting here talking about we're still the fattest. We set records on infant mortality. We're setting records on diabetes. And then you say, well, wait a minute, you've been on Medicaid. And this group are the ones that is the most vulnerable. So then you got to go back and say, well, if we add another 200,000, will the same thing happen?
Well, what we know with that 200,000 is that they will have access to screening and prevention for colonoscopies, mammograms, pap smears that they don't have now. They'll have earlier diagnosed diabetes and hypertension, hopefully, earlier chances of being diagnosed with hyperlipidemia and with appropriate treatment. All of those things that right now are not happening at all. Perhaps they are we know they're not being done as well in the Medicaid program. But again, Medicaid has its own limitations to access because it is so poor paying and poor performing. We're talking about these Mississippians having the same insurance that you and I have, Paul, and the same access to health care that you and I have. And I would argue that just like my mom and daddy, they worked hard, and they deserve it.
Is there? I know when we had Tim on yesterday, we were talking about this. Is there a possibility some on Medicaid could switch over to this and transfer to whatever you guys come up with
as their income goes up?
But they still would be confined on the income level. We are always smarter when you leave, and we thank you, sir, very much.
Thank you, sir.
Dr. Dan Edney, who is the past president and also chair now of MCare. And again, if you want more information, it is available where?
Through the State Medical Association.
State Medical Association, it is.